I want to welcome you all tonight to this webinar. I want to introduce myself. I am Doreen Hindman, and I'm the Executive Administrator for the Family Connections Program through Sashbear Foundation in Canada. And I have with me tonight Kathleen, who is one of our volunteer facilitators and also a volunteer for many other aspects of the work that we do here at Sashbear. And she will be helping me by monitoring the chat and the questions that we will get to at the end. And I just want to let you know before we get started, a couple of things about how this will work. This is a webinar, which means that everybody who's attending right now is hidden from view. So you can go ahead and eat your dinner or get up and move around as you need to. You are also automatically muted. And so in order for you to let us know if you have any questions, you can use the chat. We also have a Q&A function. So if you look at the little icons on your screen within Zoom, you should be able to see both chat and Q&A. And if you put your questions into Q&A, they won't get lost in all of the other conversation that happens in the chat, but we will keep track of them no matter where they are. I also want to let you know that this is being recorded. Kathleen's already noted that in the chat. We are going to record the presentation tonight. Dr. Federici has very generously agreed to have it recorded and made available afterwards. And we post all of the video webinar recordings on our website, sashbear.org, on the resources page, and also on our YouTube account. And so if you search for Sashbear on YouTube, you can subscribe, and that way you get a notification every time we post a new webinar there. So just briefly, I want to remind you all that the Sashbear Foundation is a charitable organization, a registered charity across Canada. We offer the Family Connections program and do other volunteer-based work towards advocacy and skills education around emotion dysregulation, which includes borderline personality disorder. Most of us are volunteers, and most of our funding comes from donations. So if you have benefited from taking Family Connections or are at all interested in it or interested in giving back to the organization in any way, please keep in mind that we are all volunteers and we absolutely welcome your donations and your volunteer time to help us continue to do this work. So I would now like to move on to introduce our guest speaker for tonight, Dr. Anita Federici. And Dr. Federici is a clinical psychologist. She is the owner of the Center for Psychology and Emotion Regulation, which is in Midland, Ontario. And that clinic specializes in the assessment and treatment of eating disorders, personality disorders, and trauma. She is a distinguished fellow of the Academy for Eating Disorders and a recognized authority on eating disorder treatment and DBT, dialectical behavior therapy. She also serves as the elected co-chair for the Suicide and DBT Special Interest Group for the Academy for Eating Disorders. Dr. Federici has had a considerable impact on the field through her leadership and expertise in this area. She has developed a robust training program, a wide network of allied health professionals, and a treatment center in an underserved rural region of Ontario. She has, over the years, provided more than 100 lectures, workshops, and invited talks. Her work has been presented at international conferences and published in peer-reviewed journals and invited book chapters. We are so very pleased to welcome you here this evening. Thank you so much for joining us and sharing your time and your expertise with us.
It's my pleasure. It's my pleasure. You know, I've been following you guys since you started, and it's just such a nice collaboration to get to work with you. And I admire all the work that you and Sashbear are doing for our communities to raise awareness. So it's my pleasure. So welcome, everybody. I have prepared a talk that I'm going to do my best to keep it between the hours of 7 and 8 p.m. But knowing me, I like to chat. So I'm going to watch the clock as best I can, because I want to make sure that I leave room for your questions that can come at the end of the talk. So tonight I'm going to talk about this intersection between eating disorders and emotion dysregulation with a particular lens toward helping families navigate. A lot of families ask me or ask my team, how do I know that my child has an eating disorder? What do I do when I know that there's something going on? How do I navigate a system that is a little bit tricky? So I'm going to try to answer some of those questions tonight, okay? And that's sort of my plan. I thought what I would cover are common signs and symptoms. So I've decided purposely not to make this a diagnostic lecture about what each eating disorder is, more to help families become aware of the unique signs and symptoms that can sort of tip us off that there's something going on. I want to give you the current information on what actually causes and then maintains an eating disorder, because there are so many myths and misconceptions out there. Those of you that are familiar with DBT, I am going to talk about how we've adapted what is called the biosocial theory, specifically for eating disorders. And I think that's important when we think about how eating disorders develop. Specifically, how does an eating disorder impact emotion regulation? This is really key. Treatment options and pathways, and I've added some select DBT strategies and help for parents, okay? So I'm going to do my best to sort of give you a flavor of all these different pieces, knowing that we're probably going to have more questions than I have time to answer. But the first part that I want to highlight is that this talk couldn't come at a more crucial time in our field. All over the newspapers throughout Ontario and in the colleagues that I have across the country, we are seeing increased rates of eating disorders, especially during COVID. I mean, it was a problem before COVID. We were underserved, underfunded, and then COVID hit. And as you can see from articles like this, the pandemic has sent record numbers of kids, children, teenagers to our hospitals, to our private practices. Like I said, in droves. I've never in 25 years seen what I'm seeing in the last year. Just to give you a bit more information, in the last year alone, the eating disorder referrals at CHEO, so the Children's Hospital in Eastern Ontario, are up 63% in youth. And that's just the youth requiring inpatient treatment for their eating disorder. Those that are presenting with eating disorders who require assessment in the emergency room, up almost 30%. 56% increase in outpatient referrals deemed urgent. CHEO has had to deny, and this is the part that, is so hard. CHEO has had to deny 73% of their referrals. They don't have the space. And this is not unique. This is happening across the province in all of our eating disorder centers. NEDIC, the National Eating Disorder Information Center, their helpline has seen a 43% increase in calls, and more than double the number of calls are coming from kids age 11 to 19. These are our teenagers. These are our kids. The good thing is that people are reaching out. That, I think, is a good sign, okay? What is a little bit unnerving is, what do we do with these numbers when we currently don't have enough options to treat them? So why is it? Why are we seeing so many people with eating disorders right now? Well, I think of it as the perfect storm. Eating disorders, as you're going to hear in my talk tonight, are associated with anxiety and depression. Right? And you're seeing that everywhere. So the more stress that we have, if you have the biology to develop an eating disorder, something like a pandemic is likely to activate or sort of precipitate the development of an eating disorder. Those disruptions to routine. We love routine. We like our schedules. Well, there are significant disruptions to that, to our home life, the way that we interact with peers, with family, and increased time on social media. And the research coming out of this is hard to ignore. Not only is there a large association with emotion dysregulation, so the more time our kids spend on social media, the more emotionally dysregulated they become. Furthermore, the more time they spend on social media, the more body image disturbance we hear and see, and more harmful eating disorder behaviors that we see. So let's unpack this a little bit more. One of the first things that people say to me is, Anita, what do I do? I'm a parent, I'm a caregiver. What am I supposed to do? Where do I start? You start here. You start by learning as much as you can about eating disorders and about evidence-based treatment. We can't actually help somebody get the treatment they need if we are not aware of what an eating disorder is. And as I'm going to share with you, many myths and misconceptions actually get in the way, not just among caregivers, but among healthcare professionals, etc. Things like this: oh, dieting isn't serious. Everybody's dieting, right? It's not a big deal. So what that you're 16-year-olds, using intermittent fasting? Come on, everybody's doing it. And eating disorders really, isn't that just a fad that teens go through? They'll just grow out of it. That's one of the things I often hear. How about losing weight and being thin? That's a good thing. Don't you want that? Shouldn't we all be trying to lose weight? Isn't it unhealthy to be in a larger body? Right? Or still the misconception that really, if someone is going to get an eating disorder, it's probably a young girl. Okay. And one of the most dangerous myths is that eating disorders are choices. Okay. So you can start to see, and maybe you recognize these in yourself or in your family of origin. We live in a culture where disordered eating and disordered views of body, weight, and shape is the norm. So we've all grown up with this. And this is one of the reasons why so many people, so many kids with eating disorders go undiagnosed, or those symptoms get minimized because, well, it's just a fad. Well, I can tell you with certainty that there's no fad here, and that eating disorders are the deadliest psychiatric illness out there. So aside from the opioid crisis, more people are going to die from their eating disorder than major depression, anxiety disorders, bipolar disorder, and schizophrenia combined. The recent stat out of the Academy for Eating Disorders says that every 63 minutes, somebody dies as a direct result of their eating disorder. Every 63 minutes. These two facts on this slide have driven my career for the last 25 years. One is, as I said, they have the highest mortality rate of any other psychiatric illness. But look at the second point. The average length of time between the onset, so when those symptoms first begin, and the first evidence-based treatment is 7 years. Some studies show 10 years. That gap is one of the reasons why so many people lose their lives and or have a very poor quality of life. And it's my mission in my lifetime to try to do everything I can to shorten that gap and to save as many lives as we possibly can. So again, I thank all of you for being here, because we save lives by promoting education. We save lives by supporting our caregivers so that they can support their kids. So what the heck is an eating disorder? And this is where I wish I was live with you in person and I would ask you what you know about eating disorders. And I don't have that luxury tonight. So I'm going to tell you a couple of things. One, an eating disorder, well, it's the presence of disturbed eating behavior. Every eating disorder, whether it's anorexia or binge eating disorder or something called ARFID that we see develop in children, every eating disorder is characterized by the inability to properly feed oneself. It's not a choice to not properly feed oneself. It's an inability to properly feed oneself. And it's also, eating disorders are also characterized by specific pathology, a drive for thinness, perceptual disturbances in how the body is experienced. Some people are highly perfectionistic and compulsive. Others struggle with emotion regulation deficits. There are very particular things that make people susceptible to the development of an eating disorder. But holy smokes, how do you figure this out? How do you figure it out in a world that is, like I said, defined by disordered eating? This slide, which is not my slide, this slide I like because on one hand, on the green, if you look at the left side, it gives you some indication. So healthier styles or more normative styles of eating, you eat regularly and you eat when you're hungry and you stop when you're full, right? And you exercise because you enjoy it, and you exercise with the goal of being healthy. Of course, healthy is an interesting word. You generally feel okay about your body. Okay, you're not obsessed with your body. You're not you don't have a high degree of self-loathing about your body, and you believe that people like you for who you are, not what you look like. Now contrast that with what's on the other side, the orange side. And again, this doesn't capture all eating disorders, but I'm trying to give you a sense of, on the other extreme, you have some people that either eat almost nothing, so they go through the day limiting and restricting what they eat, or you have people that are eating in secret or binge eating. And so they feel out of control around food. And so they eat in uncontrolled, maybe even impulsive ways, emotional ways. They hate their body. Again, the degree of self-loathing across the eating disorders is unlike anything I've ever seen. People will have perceptual deficits. So, for example, if somebody has anorexia, they might be quite thin and still believe and perceive themselves as quite heavy. And so there's all kinds of things that go on where people become very obsessive, compulsive around food and eating. And then you have all this stuff in the middle. And you know, if I go through some of these with you, you're going to recognize them. You're going to recognize them perhaps in yourself or in families, members and friends, in the community and people you work with. So as people do more of these things, we start to see what we as a psychologist would diagnose as an eating disorder. You know, so I have to ask people, you know, are you always dieting? Are you always counting calories? Do you deny yourself food? Do you do things to get rid of what you've eaten? Do you feel guilty after eating? Do people comment on your weight change? Have people been worried about you and your weight? Do you have secretive behaviors? Now, notice that the stuff in the middle, there's a lot of people out there in the world that would say, oh, well, that's me and that's me. So again, when we're diagnosing an eating disorder, we have to look at all the different variables and figure out, is this meeting the clinical significance? And what I can tell you is that there are a lot of people out there that don't even realize that they have an eating disorder. So let's talk a little bit more about this. When people think about eating disorders, they usually tell me about anorexia or maybe bulimia nervosa. Those are sort of the top two that people bring to mind when I ask them what they think eating disorders are. Binge eating disorder, this is where people engage in episodes of binge eating, and there's very rarely compensatory behaviors. So they're not exercising or restricting, or they're not doing things generally to get rid of what they're eating. There's something called avoidant and restrictive food intake disorder. We call it ARFID for short. And this is where we often see it develop in kids. And it can start by looking like picky eating, but it's much more than picky eating. And these are kids or teenagers that grow up and they have very, very specific textual experiences around food, sensory experiences. They may not like certain colors of food, certain textures of food. They might fear choking. So again, there's this real difficulty with eating, but it's not as associated with a fear of gaining weight as you might see in anorexia nervosa. They don't have the same body image disturbance, but these kids stop growing. These kids don't meet their developmental milestones. Why? Because there are these difficulties with feeding and eating. We have other categories for people that don't fit neatly into a box, because a lot of us don't fit neatly into a box. We have pica. This is where people are eating non-nutritive substances like paper or clay. That happens outside of another diagnosis like autism spectrum disorders. And then there's rumination disorder. Again, most people aren't aware of this disorder, but this is where an individual really struggles with keeping food down and will be able to regurgitate food and rechew and swallow food. So there's a lot that goes on under the umbrella. Like eating disorders is such a broad term, right? That defines many, many specific feeding and eating disorders. Okay, so I hope you're not overwhelmed yet. What can you do as a caregiver? Well, the first thing I try to arm parents with, and grandparents and aunts and uncles with, are awareness of signs and symptoms. So I've got 2 slides here. There's a lot going on these slides. So take a moment and have a look through them. Now, this is not to suggest that somebody would have to have all of these symptoms. You want to be aware that somebody might have a couple of these symptoms. My advice to you is that if you're seeing some of this behavior, this would indicate at least cause for an assessment. So if I were seeing some of these things in my daughter, I would want to have her see somebody who's trained in eating disorders and body image disturbance, just to meet with her, have an assessment. Let's just talk about what's going on. Okay. So an intense fear of gaining weight or weight changes. Okay, so gaining weight, losing weight, if you're starting to see changes in this and your kid is expressing, negative comments about their body, or they're afraid of gaining weight, that's a bit of a cue right there. Especially if their self-worth is strongly linked to their body image. So I've worked with some young kids who they won't even go out. They won't even go on social media without lots of makeup or lots of sort of prepping, because they can't stand the way they look. Negative thoughts about weight and shape, I mentioned that. A fear of eating with others. So you might start to see them withdraw from eating with the family. And sometimes that gets normalized. They're a teenager, they're just going to go watch TV up in their room, let them go. So you've got to figure out what's normative and what's not. But if you're starting to see patterns of food avoidance or not eating with their friends or other people, something's might be going on. The other side of it is that you might see your child become obsessed or preoccupied with food. So they might talk about food a lot. Sometimes I actually see this, and again, I don't know for sure what's going on, but sometimes on social media where I'll see people and all they post about is food or weight-related issues. And I wonder sometimes, geez, is that a sign that they're sort of obsessing? The more the eating disorder takes hold of your brain and your body, the more obsessed you get with food and food rituals. Cutting food into very, very tiny pieces, playing with food, not being able to eat certain types of food, a lot of rigidity around eating and food. When I start to see stuff like that, I'm concerned that something is going on. Doesn't mean it's an eating disorder, and I think something is happening. Obsessive interest in cooking. So you might have, your teen wants to cook for everybody, bakes for everybody, but doesn't eat any of it. Again, I mentioned avoids eating, going to the bathroom after eating. There's something to be aware of. I know it can seem normal. And if you're seeing a pattern where every time the family sits down to eat, your child is getting up and going to the bathroom, they may be vomiting. They may be chewing and spitting out food. Mood changes. Sometimes you don't see any of that stuff, especially with some of the teens that are good at hiding things. You might not notice it. So you might notice depression, irritability, anxiety. Okay, and I'm going to talk a little bit more about that as we go. Social avoidance. You might have a kid that used to be super social. I guess this is a little harder to tell these days with COVID. And you might start to see them withdrawing, not engaging like they used to. Excessive exercise is another symptom that's highly reinforced, right? People usually compliment you. You're so great. You're always exercising. Look at you going for another run. When in fact, that may be their prime form of controlling weight and shape, et cetera, and regulating emotion. The other signs and symptoms that I highlight here have more to do with what you might notice in the body. So when I see people in person, it's a little harder to do over Zoom. I try to look for some of these symptoms. So people might report lots of stomach problems. They're not digesting food properly. They're constipated. They're bloated all the time. And a lot of times people will go to their doctors with the stomach problems. And if the doctor's not trained in the treatment of eating disorders, and by the way, most family doctors have less than 5 hours of training in eating disorders. So the likelihood that the family doc is going to pick it up or inquire is low. So a lot of times those stomach problems are misdiagnosed when actually what's causing the stomach problems is the eating disorder. Fatigue, your kid is tired all the time, not normal for them. They're dizzy, maybe they've fainted. Menstrual changes, right? So you may find that your child has lost their menstruation for a period of time, or they're feeling cold all the time, or you might even notice sort of the beds of their fingers are sort of bluish. Dental problems. You know that one of the first professionals who tend to identify an eating disorder are the dentists. They can see the erosion on the teeth of vomiting behaviors caused by malnutrition, etc. The problem, and I've talked to a number of dentists over the years, is that they don't feel like it's in their scope of practice. They don't really feel like it's their place to say anything. So they often don't say anything. Dry skin, brittle nails, or growth of that fine hair on the body, like that downy hair. You might remember it when they were babies. I remember when my daughter was born and she had this fine hair on her ears and her neck. And I thought, oh my gosh, that's what happens with my patients whose bodies are malnourished and in starvation mode. And in starvation mode, the body's pretty smart. It does things to try to protect your organs, right? And one of those things is to create some extra insulation and some warmth for the body. Or you might notice that your child is sick a lot. So if any of these signs or symptoms are sort of flashing to you, one of the things you can do is start to do more research on eating disorders and maybe find people in our community who might be able to help you assess whether there's more going on. The other thing that I tell parents is that we have to be aware that there is no eating disorder stereotype in spite of all the myths we have. Eating disorders affect people of all genders, races, ethnicities, weights, body shapes, sexual orientations, and socioeconomic statuses. And I highlight this because I think about the young guy that came to see me a number of years ago. And he was about 17 years old. And he came in, he was referred to me for anger management. He'd been seen by 2 or 3 other clinicians over the course of his adolescence. And he came in, and I remember, and he was on the football team, and he looked like a football player, right? Tall guy, strong, and he sat down, and he wasn't particularly excited to talk to me. And I was trying to figure out, what was going on for him that other clinicians might have missed, or why wasn't it working? And I started to ask him about his eating. And he kind of looked at me and he said, I eat, I'm a good eater, and I'm really good with my body. I said, okay, can you just walk me through a typical day? What did you eat yesterday? So what I find out is that this 17-year-old is doing intermittent fasting, because that's what him and his buddies do. It's part of the football sort of program that they have. So if you're not aware of intermittent fasting, it means that people don't eat for long periods of time. And there's different lengths of time that people won't eat, but they don't eat for long periods of time. And then when they do eat, they usually eat over a select period of time. So he says, well, I have dinner, every night between 7 and 8 p.m. And then I'm doing intermittent fasting. And I said, okay, so you're just eating the one meal a day, right? And he says, yeah. I said, okay, so what do you eat during that one meal? And he says, I follow the keto diet. And I say, okay, so the keto diet is very low carbohydrates, high protein, high fat. So I said, so you're not really eating a whole lot of carbs, and you're only eating the one time during the day. So I did more assessment. And I said, how do you feel about your body? And again, he sort of looked at me and he got really quiet and he said, I hate my body. And I said, can you tell me just a little bit more? What do you mean? And he said, I am like the biggest guy out of all of my buddies. And if I don't watch the way I eat, he said, I balloon up. I get really big and I get soft. He said, I'm not one of those like naturally, well, I can't remember his words. Like I'm not a naturally like fit guy. So I could talk about this case for a long time, but what ended up happening was I said to him after finishing my assessment, I said, you don't have an anger management problem. I said, you have an eating disorder. And what I will tell you tonight is that you can't actually be emotionally regulated and have an eating disorder. Those two things don't coexist. And for this guy, because he was a guy, because he was a strong guy on the football team, because he was successful in many areas of his life, nobody ever asked him about his eating. He'd had this eating disorder for 4 years by the time I met him. And if you know about low carb diets, our brains don't function well without the proper amount of carbohydrates, right? I mean, my gosh, there was a commercial about not eating enough, right? Remember those Snickers commercials? You get hangry. Well, when people have eating disorders, like this guy, he was falling into these rages, not because he was, had anger management issues, because his eating disorder rendered him unable to manage his emotions. And after we treated him and regulated his eating and helped him work on his body image and did all kinds of other stuff, his anger was gone. Not gone. I mean, his anger problem was gone. He was able to regulate himself. And this is something that over my career, I have seen so many times. This idea that many people with eating disorders look healthy, yet may be extremely ill. And this is one of the reasons that eating disorders get missed all the time. We have to train ourselves out of the idea that weight is the marker of an eating disorder. So what happens is that, if people have lost a lot of weight, we sort of get all activated. We say, oh, you've lost too much weight and this isn't okay. Except that the majority of people that have eating disorders are actually average or above average weights. And they are still malnourished and may be engaging in unhealthy weight control practices, but they don't look ill. And like I said, athletes and those who are engaged in clean eating, which is sort of the fad right now, they may be quite unwell. In fact, many of them are. So one of the things that we always tell doctors and parents, et cetera, is that any weight gain or loss should be investigated for the possibility of an eating disorder, including post-bariatric surgery patients, which should not be your kids, but this is part of this slide. So if you see somebody who is failing to gain expected weight or height, or they're not meeting developmental milestones, those things should be investigated for the possibility of an eating disorder. It reminds me, I'll just say this one piece, it reminds me of a study showing that there were 2 teenage boys. They weren't related, it was just part of a case study. 2 teenage boys that both started in what medicine would call the obese category. So as far as the medical community is concerned, these were 2 teenage boys that needed to lose weight. So they embark on weight loss. And in both case studies, these teenagers lost a significant amount of weight over a relatively short period of time. But because they started out in a higher BMI category, even though they lost a substantial amount of weight, they still weren't in what medical communities would consider a dangerously low weight. They were still, let's say, in a BMI of 20 or 21. So what happens? Well, everybody congratulates you on how much weight you lost, how disciplined you are, how incredible you look. And nobody asks how they lost the weight. And in both cases, both of these boys were very medically unstable and presented like somebody with anorexia nervosa. But nobody knew. Nobody knew. And it delayed their treatment even further because they went another year without anybody ever asking the question. So The other thing I tell caregivers is always be vigilant about co-occurring conditions. So one of the things that parents often do see are mood changes. So they sort of often are, clients come to treatment because they're depressed, or all of a sudden they've developed anxiety or social anxiety, suicide and self-injury. I'm going to talk about that in a moment. Substance use, trauma, personality disorders. So we get what's really interesting is that we typically get a lot of referrals for all these other things. And it's during our assessment that we realize that part of the picture, at least, if not what's driving it, is the eating disorder. That was actually there first. So it's still important. I want parents, caregivers to be vigilant about these other things going on. And one of the things that is really unnerving are the high rates of suicide and self-injury in those with eating disorders. Not everybody realizes how prevalent these behaviors are in someone struggling across the eating disorder. So I'm going to just highlight a couple of studies that represent what we see in the field. So if you look at it just from the self-injury side, so if you study like these guys did, they took about 450 students and they surveyed them, and about 14% said that they had engaged in self-injurious behavior over the past year. 14%. And they started to look at, well, of those who engage in self-injury, well, what co-occurs? Well, they're much more likely to have eating pathology. And if you jump down here, they're more likely to have bulimic tendencies. So that means that they're more likely to engage in binge eating behaviors or purging behaviors or over-exercise. And they're more likely to show body dissatisfaction. They struggle with impulse regulation. They tend to feel ineffective in their lives. They have a lot of distrust and they don't feel so secure in social situations. Okay, so that tells us something. In another chart review of about 1,400 adolescents with an eating disorder, aged 10 to 21, 40%, right? Almost half of them reported engaging in self-injurious behavior in the recent past. They were more likely in this study to be female. Again, there's that bulimia nervosa piece again, or have a history of binge eating and purging, have a mood disorder, have substance use. So what we know is that people that tend to be more impulsive and emotionally underregulated, I will speak to that in a moment, are more likely to not just engage in self-injury, but to engage in substance use and bulimic symptoms, right? So we tend to see these things fall together. Here's the stuff that is also pretty scary, right? Those with anorexia nervosa are 31 times more likely to make a fatal suicide attempt than the general population. 1 in 5 people with anorexia will die from suicide. 1 in 5. And those with bulimia nervosa are 7.5 times more likely to die by suicide than the general population. So what we know is that people with more impulsive personalities, more risk takers, that kind of thing, they're more likely to engage in self-injury, cutting, burning, head banging, etc. Whereas people with anorexia nervosa are more likely to engage in suicidal behavior. Okay, so these are just things that we become aware of in the field. I'm going to talk more about that temperamental piece in a few moments. I want you to know that an eating disorder is a health crisis. So when you bring your child to an eating disorder clinic or a eating disorder professional, one of the first things that we're going to ask for is up-to-date lab work. We need to know what's going on because there are imminently life-threatening conditions that people need to know about. Bradycardia, heart arrhythmias, electrolyte imbalances, ipecac abuse. There are certain things that, for me, I won't even complete my assessment or give a treatment plan until I have the lab work, because this could be a game changer right here. And this may determine what level of care that person needs. And I got to tell you that many people will be in these boxes and look completely fine on the outside. You cannot know by looking at somebody. And that eating disorder, it affects every organ system, every system in the body, from the skin and the hair to the the GI tract, neurological, endocrine, every system is impacted by the eating disorder. So here's something else you can do. This purple book is available for free, the Academy for Eating Disorders website. Make sure that your loved one gets a full medical evaluation by an experienced ED professional, and read this little book. It's about, I can't remember, 16 pages, 20 pages. And yes, it's designed for the medical practitioner. In fact, we often tell our families, please take one of these with you to your doctor's appointment. Your doctor will hopefully will find this quite helpful in guiding what needs to be done. Eating disorders are not choices. They are serious, genetically influenced illnesses. We know that there are predisposing factors. There are genetic and biotemperament factors that contribute to the development of an eating disorder. Eating disorders run in families. And like I said before, we start to see characteristics or temperamental pieces that are born out of one's biology, one's what we call biotemperament. Impulsivity is actually biologically based. Right? So some people are born more risk-taking than others. That's that risk tolerance piece. Emotion regulation, a lot of emotion regulation comes from the way that our limbic system in our brain is wired. Okay, so some people are more able to regulate emotion than others. We know that in anorexia nervosa and in some other eating disorders, there are genetic abnormalities in the metabolic system. There's actually a call right now from researchers to remove things like anorexia from the psychiatric classification and into a neurometabolic condition. It'll be very interesting to watch how we learn more about eating disorders in the coming years. But genetics alone isn't enough to necessarily prompt the eating disorder to develop. We often say genes load the gun, the environment pulls the trigger. The environment being these precipitating factors, puberty, the changes in the body, etc., psychological events. So even, your best friend moving to another province, the death of a loved one, the divorce of parents. Now, again, those things don't cause an eating disorder because you have to have the genetic underpinning. But these are enough, these things precipitate the development. Dieting, we do not want our kids dieting. One of the biggest predictors of the development of an eating disorder is dieting behavior in young kids and teens. Illness, life transitions, that's why going to university, et cetera, can be the time when an eating disorder starts to appear. And then you've got perpetuating factors. So there are things like the eating disorder itself. By continuing to engage in the eating disorder behavior, the eating disorder is maintained. If we don't learn how to regulate emotion, eating disorders are maintained. When we idealize fitspiration or thinspiration, the eating disorder is maintained. And so the hamster wheel continues. So I'm trying to be aware of time. I told you I have a lot of stuff. So what I'm going to highlight here, the biosocial theory is just an addition. It's what I was just saying. We know that people are born with a biological vulnerability to emotional stimuli and to eating disorder behavior. And they can grow up in environments that we call that are invalidating, that don't understand them. And that's when we see, again, the behavior happen. In standard DBT, emotional vulnerability is defined as someone who's really sensitive to emotion. They pick up emotion cues all over the place. They're very, very aware of emotion. And when they feel emotion, they feel it in huge ways. And it takes them a lot longer to calm down, to come down to baseline. But that's not everybody. So in this slide, this comes from a treatment called Radically Open Dbt, which is a treatment designed for people who are emotionally constrained, emotionally over-controlled. So you see, on one hand over here, That person with bulimia nervosa, maybe, or binge eating disorder, might fall over on this side of the slide, right? Where they really have trouble regulating their emotions, really impulsive, again, engaging in lots of behavior, not really thinking through things, okay? But then you've got this whole other subgroup that are on this end of the continuum. And these guys are characterized by high emotional constraint. They're usually highly perfectionistic, very rigid in their thinking and their behaviors, socially inhibited, not risk takers. They're often socially isolated. They don't have a lot of friends. They're sort of the loners, the isolated ones. And they tend to be the ones that have anorexia nervosa or ARFID. Now, this isn't a perfect split. It's not that everybody with bulimia is under controlled and everybody with anorexia is over controlled. But what I encourage families to become aware of is that there's more going on for the person with an eating disorder. And it usually has to do with the way that they're able to manage their emotions. These slides, I've already talked about the majority of what's on these slides. What I will highlight, though, a couple of points here. Food allergies, type 1 diabetes, metabolic abnormalities, these things can be the precursors or can trigger an underlying biology for an eating disorder, right? Why? Well, someone with a food allergy starts to learn not to eat certain foods. So even though they're not trying to engage in eating disordered behavior, they stop eating as much. They might become phobic of certain foods if they have an anaphylactic reaction. And all of a sudden, they're not eating as much. And that cues something very specific in the brain. Cindy Bulick is a top international researcher. She talks about the biology of food restriction, especially for those with anorexia. She's still studying whether this is true for all people with an eating disorder. But listen to this. What is an uncomfortable experience for most, the absence of food or fluid, produces the opposite effect in folks with anorexia. It creates a sense of calm in an otherwise unsettled biology. The cueing in the brain isn't about weight loss. And that's what people think. This person just wants to lose weight. It's not. It's about soothing the biology. It's about regulating. The restriction acts like an anxiolytic. It's like taking lorazepam. It's one of the reasons why it's so hard. It can be so hard to understand and treat these eating disorders. So what can you do? Well, you can recognize that an eating disorder can compromise brain function. Okay? You can't have an eating disorder and your brain be operating totally normally. There's all kinds of literature to show that an eating disorder damages the gray and white matter along the prefrontal cortex. So your loved one may not buy into treatment. And you have to be prepared for the fact that they're not going to see the seriousness of their illness. So even when you do approach them, they're likely to say, oh, come on. Like, I'm totally fine. I'm getting straight A's in calculus. Really? How sick can I possibly be? What I can tell you is I've worked with medical residents. I've worked with really brilliant people who are extremely ill. And those two things are different parts of the brain. So I've mentioned this part. Genes load the gun. The environment pulls the trigger. And I'm going to fast forward a little bit here. What is it in the environment that can trigger or reinforce an eating disorder? And this is important for families because we can change this in our families. We can't change cultural norms per se, right? The emphasis on thinness or fitness is invalidating. It tells us that the way that we were genetically born isn't good enough unless we look a certain way. But I encourage families to take a look at their own views of what healthy is and what attitudes or beliefs get communicated within the family. Are there jokes that are made? So fat phobia, fat stigma. One of my colleagues has written about fat talk and how normalized it is. Well, actually, that's really toxic and damaging for people who are struggling with eating disorders specifically. media influences who promote dieting and body dissatisfaction, dieting within the family or the peer group, and misunderstanding the illness. So one of the common things that kind of parents say to me is, why can't they just eat? Just eat already. And I have to help them understand that, my gosh, if they could eat, they would eat. This is so much more complicated than just eat. And a lot of the work that we do in the eating disorder field is help families learn how to eat and help their loved one eat. Because the more that your kid or your loved one feels invalidated and misunderstood, the more that their threat system is activated and they can't actually take in new information, they can't actually change. So one of the things you can do is work on non-judgment and trying your best to understand where they're coming from. That's going to get them talking to you more about what might be happening. Because what I can tell you is happening is something like this. They're getting triggered, okay? Could be triggered by, I think about my client who gets triggered every time her friend posts a picture of her on social media and won't take it down. And she hates the way she looks. And she starts to feel shame. And she feels anxiety. And she has a whole rush of negative thoughts. And she wants to do everything she can to get rid of the shame and the anxiety that she feels. And so she is somebody that self-harms. And she's also somebody that engages in restrictive food behavior. So her way of regulating her emotions is to either self-harm or to stop eating. And when she stops eating, she feels better. Her brain is quieter, her emotions subdued. I have other clients that have similar experiences when they binge and purge. So what happens is that eating disorder behavior, just like self-harm, it gets reinforced with temporary relief. And so she breathes a sigh of relief and is able to go to bed at night. And then until the next trigger. And the problem for her is that she stays on this hamster wheel, right? She lives her whole life like this, trying to just get rid of something that is intolerable. And I have to teach her how to work with her emotions and the triggers and understand her biology that drives the bus in order to help her recover. So as I've said tonight, you can't have an eating disorder and be emotionally regulated. Okay. So I often say to my clients who say to me, Anita, I really want you to help me with my anger or help me with my fear or help me with my shame. And I have to say to them, it's going to be nearly impossible for me to do that with any effectiveness if we have this eating disorder on board. So we're going to have to make some tough decisions here. So caregivers, a couple of pieces that I can continue to give you as we wrap up tonight. Learn about what's out there. And I know it's scary. I know it's scary out there right now. I know there's not enough. I know the wait lists are very long. Please don't give up. Please don't. The adolescent brain needs you and needs to be properly nourished in order to develop. Full nutritional rehabilitation is an absolute priority. And this is not just for people with anorexia. This is people for binge eating disorder, bulimia nervosa, ARFID. And our greatest allies in treatment are you. The most evidence-based treatment for adolescents with an eating disorder is family-based treatment. It's a very particular type of treatment where we empower and help parents, caregivers, learn how to take control back and to save their kids' lives. Most evidence-based treatment. There are other approaches, as you can see here, depending on the age of the child, etc. And there are some amazing resources out there that I have included on these slides and that I will make sure that Sashbear has that you can start looking at right away. There are all kinds of levels of care that I want to make you aware of. And what I will tell you now is I know that there's a lot of kids getting turned away. And I know that there are long wait lists. Put your name on the wait list. If you can, keep trying, call them back the next week, keep going. Our eating disorder programs are doing everything they can right now. Teams are trying so hard to figure this out. And there's some new things coming and new ideas coming. So just keep going, okay? And what I tell caregivers is hold firm to what you know about your loved one. If you know something's not right, trust your gut, trust your instincts, and be an empowered advocate. Push for further diagnostics if you feel that something is wrong. I had a young woman in our clinic, and her heart rate was 42, which is bradycardic, and it could lead to imminent death, okay? We don't bring her, we tell her she has to go to the doctor. She goes to the doctor, and the doctor smiles at her and says, you're fine. You've got the heart of an athlete. And the mom called me in a panic, and I said, go to Emerge, go to Emerge. They go to Emerge. She was admitted right away, thank goodness, because that doesn't always happen. She's bradycardic. You know, her heart rate, if her heart rate's 42 when she's standing there talking to you, what happens at night when she lies down for 6 hours? And that's one of the main reasons why our patients die so much. They have major things going on. So mom, dad, grandparents, aunts and uncles, trust your gut. There are a couple other pieces that I added here. I know that we're almost at time. I want you to remember that your son or daughter, they are doing the best they can given their biology and what's reinforced. Okay, so even though they might argue with you and might not want to go see somebody, we have to remember that they're doing the best that they can, and they're doing their best to survive. And that eating disorder is telling them things that is leading them down the wrong path. Okay, so if I had more time tonight, I would unpack this slide. But I want you to know that they are doing the best they can, and they've got to do something different. Try to stay out of the fight. If you do go talk to your kids, we tend to look for a right and a wrong way to do things. We tend to look for, who's got the right answer. The dialectical approach is that there are multiple truths in a given situation. And I'm going to highlight some of those to you if you'll give me maybe 5 more minutes. So we're going to use dialectics and validation just in a couple more slides, just to highlight to you how I might start to talk to a loved one with an eating disorder. Remember, when you validate, you are communicating what is valid, what makes sense about their thoughts or emotions or behavior. But it doesn't mean that you approve or agree or respond warmly. So let me give you a couple of examples. Hang on, I'm going to go over here. So you want to validate the valid. What makes sense? What makes sense is that somebody wants to feel better. What makes sense is somebody wants to feel safer, more grounded. That makes sense to me. It makes sense to want to reduce intolerable sensations in the body. Nobody likes to feel that. It makes sense to want to fit in, to be noticed, to be loved. It makes sense to want to reduce distressing thoughts and emotions. So you can validate that all day long in your loved one. What I want you to not do is validate what doesn't make sense. It doesn't make sense to starve yourself as the way to find safety. I might say to a client, I know you want to reduce what you feel in your body. And purging or using laxatives is not actually an effective way to do that. I know it might feel that way short term, and in the long term, it actually makes it worse. It doesn't make sense to follow unhealthy influencers on social media as a way of building up your sense of self-worth and reducing negative thoughts. In fact, following unhealthy images and influencers on social media makes you feel worse about yourself. So there's a very fine line between validating a valid behavior versus an invalid behavior. So here's an example. Let's say your loved one wants to skip meals. What the heck am I going to say? Well, I might say, look, I know your brain is telling you right now that not eating is the answer to feeling better. I know that that's what feels right for you. I know eating food is really hard. I hear you. It is super scary. That's a validating response. And I add in the dialectical stance, which is that there are multiple truths here. And I need you to join us for dinner. How can I help? Now, I'm not suggesting this is going to solve all the problems. What I start to teach families is how to speak to each other in a different way that's going to keep the emotional dysregulation down. Another example, your loved one doesn't want to go to treatment. They don't want to go to an assessment. You think that there's an eating disorder, they don't want to go. How do I validate? What's valid here? I can only imagine how anxiety provoking this treatment is, or going to see Dr. Federici. That's probably uncomfortable. How hard it is to turn over control to a treatment team that you don't know. How hard it is to go sit with someone you've never met, who's going to ask you a bunch of questions that you're not even sure you want to tell them about. Yeah, that probably would make me feel uncomfortable too. Validation. Add in a bit of push for change. And hun, you are medically unstable, and we need to focus on that. Notice that both things are true. Okay, as opposed to, listen, I made the appointment, I need you to go, get in the car, right? Which is what happens, because poor parents are also frustrated and burnt out and scared to death as well. Last one, I promise, right? Let's say we have clients all the time who say, you know what, if you're going to make me eat this dinner, I'm going to kill myself. And I'm going to do it when you're sleeping. I don't know. I mean, how does a parent, my God, that's so scary. We deal with this all the time. And I might say something like, I know that eating this meal is the last thing on this planet that you want to do. And it feels like you have absolutely no choice. And it sounds like you're getting desperate to find a way out to get away from this. I'm validating what makes sense. It makes sense that this is scary. You have a brain-based illness that is screaming at you not to eat. That you are thinking that it would help you to end your life rather than eat this meal. That's a serious thing going on there. And I know you don't want to be dead. Now, this has a particular context, because I know, for example, let's say in wise mind, I know that you don't want to be dead. I know that you don't want to be dead. Is there another way we can handle this together tonight? What sometimes happens is parents will back off and say, fine, okay, don't eat, just don't eat. Okay, fine. Which actually just reinforces the suicidal sort of behavior as the way to get out of what's terrifying. And I don't want to do that. Or sometimes we get really frustrated and we say, really? Okay, I'm going to call the police right now. And we say it in a way that's also sort of scary and threatening, and it just escalates. So I wish I had more time with you tonight. There's so many things I would love to share with you. The most important thing I think I can tell you is that there is so much hope out there. Do not get discouraged. You are the best advocate for your loved one. So speak up, be seen, be heard. And these are just some of the amazing organizations. Need, Feast. Feast is incredible. They have a 30-day, I believe it's free, Eating Disorders 101 for parents, rave reviews. I love the folks. I love all these folks, frankly. The National, NEDIC, Body Brave. Oh my God, Body Brave stuff is on par, and it is so good. Sheena's Place, Waterstone Foundation. There are so many people, so many parents, so many people out there who have resources for you. So please reach out, talk, and keep learning. And if myself or my clinic can help in any way to provide information or to send you in the right direction, or you want books or you want to know more, please reach out. I'm happy to be a resource as best as I can. You can follow me and my team on social media. I try to do my best to provide education. And oh my gosh, I'm at 8:04. Thank you for listening. Thank you so much for being here. It means everything to me and to the families and communities that we treat. So thank you.
Wow, that was fabulous. Thank you so very much. We have several questions that have come in already.
Okay.
And I know that now that I know everybody was focused on listening and reading your slides, and now they will start typing in many more questions. So we'll do our best to filter through them. And I'm just going to leave your slide up there for another minute, and then maybe we'll take it down so that we can actually see you a little more clearly as you're answering the questions. First of all, I just want to say that you've spoken a lot about the DBT things that caregivers can do. And so those people who have taken Family Connections, a lot of this would sound really familiar to you. If you have not taken Family Connections and you're on our wait list, we hope to be able to offer groups again. We will be offering groups again in June, and we do have typically a few month wait for people to get into it. But if you signed up a few months ago and you want to know where you are in the wait list, you can email me to find out when you may be getting in. And so I just want to call that out because there are resources that more generally talk to some of these points. A lot of the questions have come in specifically around this idea of getting people into treatment. And I think you did a great job. Thank you so much for addressing that already with this idea of validation and then pushing back with the dialectic. So hopefully that helps some people. A lot of people are confused about what might be the best or first kind of thing to approach in treatment, where there are different diagnoses and different comorbidities. So if we've got an eating disorder happening, but we've also got BPD and we've also got PTSD, do you try to hone in on one of the diagnoses first and get treatment for that? Do you try to find a general package approach?
It's an excellent point. It's an excellent question. And myself and my colleagues have really spent most of our career looking at that, what we refer to, and I hope it doesn't sound invalidating, but sort of that multi-diagnostic presentation. This isn't just someone with an eating disorder. This is someone with, BPD or suicide, self-harm. So, and it's one of the reasons why patients like this, clients like this fall between the cracks. Because if you go to let's say a standard eating disorder treatment center, what happens is that team, although fabulous, right? They're not equipped to manage the strong emotion dysregulation, the ongoing suicide, self-harm, and the concurrent trauma. So what has happened to a lot of our clients over the years is that they are discharged from services, or they feel like they failed treatment because they couldn't get the treatment they needed. So a lot of times I remember 20 years ago, we would discharge people who had suicide or self-injurious behavior and say, you need to go work on that and then come back. So our patients would go over, let's say, to CAMH, to the BPD clinic, right? And the BPD clinic, also amazing, fabulous clinicians, right? They would do an excellent job of targeting self-harm, suicide, personality disorders. And clients would learn a lot. The eating disorder would remain intact because they weren't an eating disorder service. So then sometimes the DBT centers would say, your trauma is really getting in the way. Let's send you to RAP or another trauma program. And then the trauma program would say, well, but you have an eating disorder and we're not an eating disorder service. So this is where DBT has become the powerhouse for these folks. What I would tell you is that, and I can send you research papers. So if somebody wants to see what has been written in the field about this, please send me an email. Happy to give those to you. What I'd be looking for if I was a parent with somebody like this, or was developing a treatment center, and this is why my center is 3 main tracks: eating disorders, DBT, trauma, because of the co-occurrence of those things. And I find that the DBT for eating disorder model allows us to target all of those behaviors concurrently instead of trying to piece them out and sort of silo the treatment. That doesn't work. That said, what I will tell you is that trauma work, it really depends on the case. If somebody is actively suicidal, self-harming, and is really ill with their eating disorder, it's not the time to start hardcore trauma work. I'm going to work on behavioral stabilization. And once I can get them able to regulate emotion and deal with some of the body image disturbance. Okay, let's get to that trauma. Okay, so that's my short answer.
Thank you. And I know every situation is going to be unique, and so you can't provide an absolute general answer. Now, you're answering this from your perspective as an expert in eating disorders with DBT training. So for someone who may not have access to someone with your particular expertise, is it the same type of thing that you look for DBT, you look for somebody with specialization in eating disorders and hope that they can tackle it?
You keep looking, we field a ton of calls. We know, at least in our province, who those people are. There's some amazing clinicians who do both. So yeah, I would look for someone that is DBT trained and has eating disorder experience. And that's going to be hard to find. And it's one of the reasons why I try to do so many trainings with hospitals and clinicians to try to upskill. So yeah, look for people. I find that the DBT trained folks really are well equipped to handle the multiple problem behaviors going on. However, though, if they have no experience with eating disorders, sometimes they will misunderstand eating disorders as another emotion dysregulation issue and miss that you can't lose sight of the food and eating. Eating disorders are about food. You can't ignore that, right? You have to be monitoring, checking that, weighing people. It's a whole specialty. So yeah. So look for people that have both. That's your ideal setting.
Okay, great. And sorry, I'm just looking at the questions here. I guess the question that comes up over and over again is that, okay, we know the resources are out there, but those wait lists are so long. And so your response was just, keep at it, don't give up.
Okay, please don't give up. Please don't. Keep at it. I know it's a problem. It's a crisis. It's a crisis. I'll validate that. And there are some, and I know this isn't enough, but please, until we can figure something else out, there are some incredible books written. Like I said, feast.org, the stuff that they're doing to help support our families at this time, outstanding. Maudsley Parents, all of these sorts of things. So I will actually maybe give you guys some more book ideas, right? Depends how old your kids are too. Teenagers, 17, 18-year-old, there's a lot of great self-help books, that you might just start to help them read. We know that there's even a guided DBT for eating disorder self-help protocol that has shown to be evidence-based. So there are things that we could at least, thank you, Doreen, she's just on top of it, plugging things out there, right? So there are things that you could do, and I'm happy to get those research papers to you. So.
Okay. And I know your website is also got resources listed on it, I believe. Is that right?
We do. We're still working on our resource page. So there's more information about eating disorders on our website. And we're actually in the process of putting together a much more robust resource page. So that will be coming probably in the coming weeks.
Okay, great. Kathleen, maybe you can pop her website address back in there for people as well. I have a question here. How do I help my child quiet her brain so that it stops yelling at her when she eats?
Yeah. Well, that's going to take several different strategies and some trial and error. Don't underestimate the power of validation. So when you validate effectively, you soothe the threat system. So the more you can say, like, I get it, like, this is really, really hard, and that voice is yelling at you. So you can use validation to your advantage and hers. I would help them externalize, like, that voice, like we do in states of mind. Those of you that know DBT, emotion mind. Well, that's kind of like eating disorder mind. It's not actually you talking, it's this sort of insidious devil on your shoulder, right? And so sometimes I sort of say, like, can you imagine like this annoying devil on your shoulder that's actually feeding you fake news? Ah! Flick him off. Like, so some kids have a really creative imagination and can start to do that kind of thing. And, helping them eat, because I know this is hard. Distraction skills. So your distress tolerance skills are very powerful when somebody is eating. So what would help them distract? Mindful eating for someone who's refeeding or trying to eat is not the time for mindful eating. Okay? It's not. That works great if you have binge eating disorder, not if you are trying to refeed or get more food into your child. Find and talk to them outside of the meal. So don't wait till the meal to try to problem solve what might work. Wait till you guys are in a wise mind or a calmer place and generate some solutions. So I have some clients, they like to play like the ABC game, right? Like, so, okay, we got to pick cities or animals. A, what's an A? B, let's go. Because if I am activating your prefrontal cortex, I'm drawing, believe it or not, I'm drawing blood flow away from your emotional center of the brain. So it's harder to be dysregulated when I'm using this part of my brain. So I would be, holding ice could work. And at the end of the day, they are dysregulated because they're underfed. So we've really got to be careful not to not feed them, because the more they don't eat, the more dysregulated they get.
Mm-hmm.
Okay, you're doing the right thing. Stay calm, right? And keep connecting with these, keep connecting with these sites that I've given you, because there are just so many suggestions and strategies in there.
Great. Thank you. I have another question, and then I'm going to throw it to Kathleen. So Kathleen, get ready. Somebody's asking if there's a role for medication in treating anorexia, and I would assume in any other disorder as well.
So I'm not a medical doctor. And so I just want to make that clear that I'm not, what I can tell you from the research is that unfortunately, there is no medication that is indicated for the treatment of anorexia nervosa. There's all kinds of studies ongoing looking at, there's been studies looking at Prozac, et cetera. The fascinating thing when you're underweight is that a lot of the medications can't be metabolized properly, so they're not effective. So anorexia is trickier. For bulimia nervosa, the medication that is indicated is Prozac. Okay, so that is FDA approved and used for bulimia nervosa. Interestingly, there's research showing that, now you've got to hear me here. So this is not for all eating disorder. This is for binge eating disorder. It's a very particular type of eating disorder where stimulants are helpful, because there's a large overlap between ADHD and binge eating disorder. And you would never give a stimulant to someone with bulimia or anorexia nervosa, contraindicated. We also have to be mindful that adolescents are trickier than adults. Adolescents have to be carefully monitored because they can develop suicidal thinking because of antidepressant medication. So this is where you want to be working with an adolescent psychiatrist who knows what's going on. Now, it doesn't mean that we don't, a lot of my patients still take antidepressants or still use mood stabilizers for compulsivity, obsessionality, depression, etc. So medication can help with some of those other things. And medication for eating disorders is very, very limited. We know that it's very behavioral and psychological treatment that needs to happen.
Okay, thanks. Kathleen, do you have a question that desperately needs to be answered? They all do.
They all do. Yes, that's a good point. So this one question is a little bit different than the others. What do we do if our child refuses help, refuses to see the doctor?
Refuses to go? Sorry, refuses to see the doctor? Well, this is where I would, first of all, one of the things I teach families and clients is that every behavior has a function. Every behavior. I don't care how difficult a behavior seems. And when you look at all behaviors, so even resistance, I don't want to go, not going, or self-harm or angry outbursts, if you look at any behavior, what most of them distill down to is self-preservation, safety, self-preservation. That person, I guarantee that kid's probably feeling threatened, scared, and they may have been reinforced before even. Like, so if you tend to give in when they say no, well, they're going to say no, right?
Yeah.
They're smart, right? And, you know, and if you tend to reinforce when they get really loud and they have more of a tantrum, if you will, then you're teaching them that the way to get what they want is to get loud. So I look for, like, so I would sit down, I'd have a heart to heart and say, you look absolutely angry at me or terrified. Tell me what's going on. Why are you digging your heels in? And if you don't have a great relationship with them right now, who does? Is it an aunt, an uncle, a sibling? Who could sit down with them and say, we love you, we are worried about you, and I got to get you to that doctor. And you look, so notice how I'm using dialectics and validation, right? It makes sense that you're scared. Most people don't want to walk into a specialist's office and talk about something, right? You know, like that's a scary thing. And look at the and, right? And I need you to go because it's my job as your mom. It's my job. You remember when your kids were small? I don't know if you had to do this. I had to do this. My daughter from she was like 3 months old, she hated needles. And my pediatrician, who I loved, he would say, you need to hold her down. You need to hold her arms. And I was like, what? I can't do that. And he was like, Anita, she needs the shot. You're her mom. You need to keep her arms down. And I remember feeling mortified the first time I did it. And then I realized, you know, Anita, sometimes the tough job of being a mom is saying, I'm taking you. I'm going to hold down your arm to give you that damn needle so that something worse doesn't happen to you. Now, I don't want you to have to hold down your kids. That's not what I'm saying. Okay. What I'm trying. And I think give them some space. Try to talk to them, you know, talk to them maybe before you book the appointment, see if there's someone they're willing to see. Maybe they don't want to talk to a man about it. If you've got a male doctor, like maybe they're willing to talk to another female, if it's female, like, you know, like, is there a way we could figure this out? Could you go for 15 minutes and not the full hour? I've had a lot of kids come in under that guise and they stay the whole hour with me.
Wow.
Now, okay, it's not everybody. And it's a lot of people. So you got to use your kind of commitment strategies and your, you know, some of the things that we teach in Family Connections and in other places.
Okay, thank you for that. That is very helpful. Now, this one you may have already answered a little bit because I've been doing a couple of other things while I'm listening. What else besides talk therapy do your therapists implement in eating and other disorders? For example, somatic work. And then someone else had asked, can
Hypnotherapy, I think I saw. Okay, so we like other eating disorder services, we try really hard. Our goal is to offer the most evidence-based treatment possible because I believe that that's what people deserve. Right? You're coming to me because I'm an expert on eating disorders and DBT. I'm going to make sure that I'm giving you that treatment.
Right.
And so CBT, FBT, et cetera, and DBT for eating disorders have the highest evidence base. So before I'm going to try something else, I'm going to want somebody to try that modality. So if you've never had eating disorder treatment, I might not even go to DBT yet, because many people respond just fine to CBTE, cognitive behavior therapy, designed for eating disorders. Okay, so that's important to know. We do, like I said, we really do mostly CBT, CBTE, DBT, emotion reg. Before COVID, I have this whole other platform. Like, I really love yoga. I think there's a huge place when people are medically stable to work with. So I have a whole body image platform.
Okay.
But I can't run it right now because it really is meant to be done in person. And I haven't quite figured out how to do it on video in the same way. So I think that there's a lot of things that can be very helpful that are body-based or movement-based. And there's all kinds of journal articles about this. You just got to be careful. You don't want someone who overuses exercise to say, well, I'm going to go to hot yoga because this is good for my body image. You got to watch that, right? You got to, so you got to be careful with those things. Hypnotherapy, I don't have evidence that hypnotherapy is it's not known as an evidence-based treatment for eating disorders. And, if somebody's tried everything, like if you've tried multiple treatments, I think you have the right to try other modalities. My stance, though, is if you've not tried the evidence-based ones, please try those first because they have the most data.
Okay.
Right?
Great. Thank you for that. I felt that was helpful. So that's really good. So those are the questions that I have, because the other ones that I have were overlapped with Doreen. So Doreen, I don't know if you have any new ones that have just come in.
At what point do you know that a particular treatment won't work and it's time to move on to a different one?
Okay, excellent point. Well, the literature will tell you, let's say you're in family-based treatment, right? We're working with adolescents. Generally, if you're not seeing a response, a behavioral response in the first four weeks, 6 weeks for sure, you're unlikely to see a good outcome. So when I train clinicians, I train teams, I say, you gotta be watching. So are they gaining weight? Are they losing weight? Did they stop purging or not stop purging? Like if you're 4, 5, 6 weeks into treatment and that behavior is not changing, you probably need a higher level of care. Or you need a different treatment. So there are different things to consider in eating disorders. One is the actual treatment itself. Is it DBT? Is it CBT? Like, what is it? Okay. The second piece, though, is level of care. And there are some patients that we must wrap more around them and the family, because seeing us even once or twice a week is just not enough to help someone learn how to eat again. Or for the first time. It's not enough to manage all the suicidal behaviors and the therapy interfering behaviors and the parents' burnout. So some people respond, but I tend to look across therapies. If I'm not seeing a change in DBT, like if someone's coming into DBT, that can take a little bit longer because there's just so much going on. Mm-hmm. And I'm still seeing some changes, right? So if you're really not seeing changes in the first 4 to 6 weeks, I would be really thinking about what's working and what's not. Yeah. And just so you know, it's normal. I would have most of my clients get on a waiting list if they can, even if they're like, I'm not going. You know what? Let's just have a plan B, C, and D just in case. 9 times out of 10, they end up going when they need to go. So don't be surprised if your treatment provider wants to get blood work done and wants to put you on a wait list for eating disorder treatment. You can always decide not to go, but geez, you don't want to get 5 months into treatment and then say, I'd like to go. And now it's another 5 months of waiting.
Yeah. Yeah. It's heartbreaking.
It is heartbreaking. It is heartbreaking. And at the same time, I will just say, I have seen more energy, advocacy, media awareness, and government interest in the treatment of eating disorders now than I have in my whole career. And that, like, I get goosebumps. That says, okay, it's hard right now, but just keep going. Just keep going.
Great. So there may be light at the end of the tunnel.
There's definitely light at the end of the tunnel. There is, and you can't do it alone. You need people around you. So keep reaching out.
I have one last question that I'm going to ask you, and then I want to apologize to everyone because we could not get to all the questions, and we really need to let everyone go tonight and respect Dr. Federici's time as well. But this question came up from the beginning and has been repeated now. What do we do when our loved ones are denied help simply because they look healthy? And for me, what this, like you talked at the beginning about these myths about eating disorders, and I immediately thought, well, medical professionals probably hold these myths as well.
100%. 100%. And I'm not judging, everyone's doing the best they can given what they learned. What I would tell you to do, my short answer is, as you learn more, you go back with those medical guidelines, go to a different health professional, keep turning over, more rocks, educate your health professional. Look, they are going to get to, I've had eating disorder programs that have said, your weight is not dangerously low enough, basically, for us to admit you when the person is so ill. Like and it's hard because our system's overrun. We don't have enough resources. And, I have doctors all the time who say, I'm not going to do this blood work, Anita. Why would I do this blood work? And some of it is because the patient or the family, they haven't explained to the doctor what's going on. Sometimes I write letters. I've written a lot of letters where I ask very kindly, this is part of evidence-based protocol. Could you please? So sometimes you get a psychologist or a practitioner involved, right? Mm-hmm. And we'll help. We'll do everything we can to help. We're trying.
Yeah. Okay, great. I think that can also give parents and family members maybe a little more hope that we can simply go back again and again as we increase our own knowledge and do that advocacy work. So thank you so much. I apologize to everyone out there who we did not manage to answer questions. Please check out Dr. Federici's website, some of the other resources. You can email me, fcprogram@sashbear.org, if you would like a copy of the slides, which she will provide to me and I can forward on to you. We will post the recording. It can take us a week or two to get it uploaded, but it will be posted on the resources page of www.sashbear.org and on our YouTube channel, also the Sashbear Foundation. So once again, thank you so very much. This has been so absolutely fascinating and heartening, and I hope that it has been hopeful for a lot of the people watching. And I know that everybody, I can tell already from the comments that I'm getting in the emails that are coming through, people really have really appreciated it. Thank you so very much for being here tonight.
Thank you for having me. It's my pleasure. It's my pleasure. Thank you, everybody, for being here. Right? Thank you.
Good night, everyone.
Good night.